This presentation describes a biomechanically rational approach to diagnosing pseudarthrosis. There are many publications that address the clinical importance of diagnosing pseudarthrosis, including this paper by Coons et al., which concluded, despite findings that pseudarthrosis after attempted ACDF can be asymptomatic, pseudarthrosis is recognized as a potentially poor prognostic factor and is thought to be a common cause of persistent neck pain and/or radicular symptoms after ACDF. Accurate diagnosis of pseudarthrosis is important. Intervertebral rotation and translation are common metrics used for the diagnosis of pseudarthroses. While frequently applied in studies and clinical practice, their sensitivity and specificity are not well established. These metrics, derived from flexion-extension X-rays, aim to determine fusion success by identifying motion. However, there's uncertainty about the optimal threshold of rotation or translation that optimizes diagnosis of pseudarthrosis. The accuracy of these metrics relies on the patient's effort in flexion and extension. Inadequate patient effort might falsely indicate fusion when there's none. There is currently no standardized test for pseudarthrosis in clinical practice. This table from Oshina et al. Documents the wide range of criteria that have been explored. The challenge of optimizing diagnosis of pseudarthroses has not been solved. A level that one clinician considers fused may be diagnosed as a pseudarthrosis by another. Strain may be a biomechanically rational basis for the diagnosis of pseudarthrosis. Strain is defined as the change in length divided by the initial length as illustrated in this diagram. It is well known that strain is a critical factor in the biomechanics of fracture healing. The strain tolerance between bone fragments varies based on the tissue type at the fracture site. Early stages tolerate more strain, while later stages involving bridging bone tolerate much less. When strain drops below 10%, bridging bone starts to form, and with even less strain, bone can bridge between fracture fragments. This understanding is pertinent to spine fusions. Bone biomechanics have been extensively studied. Bone will initially behave elastically, meaning that when the load is removed, bone will spring back to its initial condition. If loaded past the elastic region, it begins to yield and then it fractures. From the work of Kivini et al. And others, we know that the failure strain of bone is fairly constant across anatomic sites and even species. One thing can be stated definitively. Bridging bone cannot exist if the strain is greater than the failure strain of bone. We can measure the apparent strain across a spine fusion site from flexion-extension X-rays. We cannot measure the strain that occurs in individual spicules of bone from X-rays, so we reference the overall apparent strain. Multiple studies agree that the apparent strain is under 5%, and work of Kivini et al. And others document trabecular bone failure strains of less than 2%. Consider why an anterior plate is applied in ACDF surgery. It is to provide initial stability. Why is initial stability important? Bridging bone cannot form if the strain is not reduced to below the failure strain of bone. The apparent strain will depend on where the strain is measured, with anterior strains different than posterior strains. We can measure strain at multiple points across the disc space to understand where strain may be low enough to be compatible with bridging bone. This figure illustrates how anterior and posterior disc strain measurements are made. To test the potential of strain-based fusion assessment, we need to choose a threshold level of strain that would identify a lack of bridging bone. Based on data from Kivini et al., the failure strain is under 2%. We have determined the error in the strain measurements to be approximately 3%. Therefore, strain greater than 5% is considered evidence for a lack of bridging bone and can be used to diagnose a pseudarthrosis. We reanalyzed data from a previously published study by Gaselli et al. Addressing methods to assess ACDF fusion status. In that study, intra-op assessments were available in addition to flexion-extension X-rays. Gaselli et al. Concluded that intervertebral rotation with a threshold level of 1 degree was sensitive and specific to the results of the intra-op assessment. In the reanalysis of the data, we found that strain was as sensitive and specific as rotation for diagnosis of pseudarthrosis. The strain threshold that gave the best balance of sensitivity and specificity was 4%. To further understand strain after ACDF, we pooled together flexion-extension X-rays post-ACDF for 1,369 patients. We had multiple time points per patient, providing apparent strain data for 8,901 levels. To reduce the chances of falsely classifying a level as fused only because the patient did not adequately flex and extend, we limited our analysis to only time points where the strain at adjacent levels was greater than 10%. We focused on strain at the anterior and posterior most aspects of the disc space. The data document average anterior strains being initially lower than posterior strains, presumably due to the anterior plate. We found a gradual decline in strain that was more rapid in the first 24 months and then more slowly declined out to 84 months. We found more variability in posterior versus anterior strains. Anterior and posterior mean strains were under 3% at 84 months. Note that median strains go below 2% with long-term fusions, consistent with failure strain data for trabecular bone. As a side note, relevant to the issue of the effects of ACDF on adjacent levels, anterior and posterior strains at the adjacent levels initially go up after ACDF but then gradually return to initial levels. It is important to consider the differences that can be expected when comparing strain-based to rotation-based fusion assessment. Based on the pooled data analysis, strain and rotation were correlated, though there were differences. Note that with strain-based fusion assessment, it is possible to separately assess anterior and posterior strain and thereby look for the possibility of partial bridging, for example anterior but not posterior bridging. This is not possible with rotation-based assessment. When rotation is over 2 degrees, strain will always be over 5%. However, when rotation was less than 1 degree, there are levels with strain greater than 5%, and this supports that strain-based assessment may find pseudarthroses that would be missed with rotation-based assessment. Our recommendations based on current evidence are: first, collect high-quality flexion-extension X-rays with good patient effort. We recommend a protocol described in an online video. Then obtain the disc strain report and verify that strain at adjacent levels is greater than 10% to help assure that the ACDF level was adequately loaded. Then, if strain at the ACDF level is greater than 5%, use stabilization to scrutinize the level for intervertebral motion that is consistent with either a pseudarthrosis or a partial fusion. This is an example of applying the recommendations. On the right is a stabilized video of a single-level ACDF at 12 months. Stabilized means that one vertebrae, in this case C7, is held in a constant position on the display as the flexion and extension X-rays are alternately displayed. From the strain report on the left, the rotation is less than 2 degrees, but maximum strain is 27%. Confirmed by the strain metric in stabilization, this level is diagnosed as a pseudarthrosis. Here is another example of applying the recommendations. This is a strain report for a multi-level ACDF. Rotation at C4-C5 and C5-C6 is less than 1 degree and strains at these levels are less than 1%. These levels would be diagnosed as fused. Rotation at C6-C7 is 1.8 degrees, and with anterior and posterior strains greater than 5%. Depending on the rotation threshold used to diagnose a pseudarthrosis, this level could be diagnosed as fused or a pseudarthrosis. Based on strains, this level would be diagnosed as a pseudarthrosis, and based on stabilization, C6-C7 is not fused. Thank you for considering this brief presentation on the potential of using strain to improve the diagnosis of pseudarthroses.